Hello, my name is Jessica Pierce, and I will be presenting my applied research project as a part of the degree requirements for the Doctorate of Athletic Training program at AT Still University. Low back pain is defined as pain that occurs posteriorly in the trunk between the 12th rib and the iliac crest. Low back pain is reported frequently in the general population and is the leading cause of physician visits, limitation in physical activity, and years lived with disability. Low back pain can affect patients of any age and has been shown to increase in prevalence with age. Because of the prevalence of low back pain, it is likely that patients cared for by athletic trainers will experience low back pain. Lifetime prevalence for low back pain within the athletic population is suspected to be between 36 and 88% and varies based on the sport. Military service members have reported prevalence rates as high as 77%, and prevalence rates of industrial workers ranges from 4 to 69%. Low back pain is often self-limiting, but may become chronic. Chronic low back pain can lead to a substantial loss in playing time, military duty availability, and work days. Patients that receive medical care early report decreased pain, increased functional capacity, and are able to return to play, military duty, and work sooner. Recent research has sought to describe the epidemiology of low back pain in populations that may receive care from athletic trainers. But to our knowledge, previous research has not described a group of patients receiving medical care directly from athletic trainers for low back pain. The purpose of this study was to describe patient, injury, and treatment characteristics of patients with low back pain that seek medical care from an athletic trainer. A retrospective analysis of de-identified patient data was conducted through the Athletic Training Practice-Based Research Network and the Core AT-EMR. Data were extracted from patient case information entered during routine daily care from 2009 to 2021 at 68 clinical practice sites across 21 states. 171 athletic trainers provided patient care and documented patient interactions in the Core AT-EMR during the study period. Patient cases were chosen based on the ICD-10 diagnosis code pain low back and were extracted using a unique identifier assigned to each patient case. Data were extracted from 4 forms within the Core AT-EMR: the injury demographics form, the initial evaluation form, the daily treatment form, and the final discharge form. Summary statistics were used as appropriate to describe patient data. These included frequency count, percentage, mean, median, and standard deviation. The variables of interest for this study were patient, injury, and treatment characteristics. Patient injury characteristics were extracted from the patient demographics and injury evaluation forms and included age, biological sex, site setting, activity, time of season, and mechanism of injury. Treatment characteristics were extracted from the injury evaluation, daily treatment, and discharge summary forms and included type of service, number of visits per case, number of services per visit, number of services per case, and total duration of care. 460 patient cases were analyzed, including 234 male and 226 female patients. The majority of the patients ranged in age from 14 to 18 years, followed by patients 19 to 23 years old and patients over the age of 30. Overall, injuries were most likely to occur in patient cases involving football, volleyball, basketball, and soccer. Injuries most often occurred for male patients involved in football, basketball, and industrial work. For female patients, injury was most likely to occur for patients participating in volleyball, basketball, and soccer. Overall, the most common mechanism of injury was insidious onset, which accounted for over 50% of all low back pain cases. During the study period, athletic trainers provided 3,817 units of service. Patient care lasted a median of 8 days, with the longest patient case lasting 80 days. Patients with low back pain visited the athletic trainers a median of 3 times per patient case and received a median of 2 units of service per visit. The most common services provided by athletic trainers included hot and cold packs, manual therapy techniques, therapeutic exercise, and electrical stimulation, with most of those services provided during daily treatments. To our knowledge, this is the first study that describes patient, injury, and treatment characteristics of patients with low back pain managed by athletic trainers. Patients treated by athletic trainers participated in athletics, military duty, and industrial work. Overall, low back pain most often occurred in patients participating in athletics, but when categorized by biological sex, male industrial workers were among those that most often experienced low back pain. Published prevalence rates for low back pain are similar for those participating in athletics and industrial work. A multitude of factors can separately attribute to low back pain for each group. However, some common factors exist between the groups regardless of biological sex, sport, or occupation. The factors include higher mechanical loads that require greater physical demand and repetitive flexion, extension, and axial loading that place stress on the lumbar spine. Our study shows that athletic trainers care for patients across a variety of activities and occupations, and as athletic trainers become more prevalent in settings outside of athletics, future research needs to explore the value athletic trainers can add to patient care in these settings. Insidious onset was the most commonly reported mechanism of injury across all patient cases, regardless of biological sex. For each of the groups in this study, insidious onset injuries are prevalent and are often a result of the repetitive stress and physical demands that are necessary to perform athletics, military duty, and industrial work. Patients may not seek care for insidious onset low back pain until it becomes severe, which may risk the patient developing chronic low back pain. Future research should focus on exploring whether ease of access to athletic trainers at various patient settings may lead to an increase in patients seeking care for low back pain at an earlier time. Patients received treatment for low back pain for a median of 8 days, with the longest recorded case lasting 80 days. Chronic low back pain is designed as low back pain lasting longer than 12 weeks. Therefore, all the patient cases in this study could be classified as acute or subacute low back pain. Low back pain lasting longer than 12 weeks may become resistant to treatment, which can lead to smaller reductions in pain and disability than low back pain that is treated in the acute or subacute phases. Availability of an athletic trainer to provide early interventions for low back pain may lead to a decrease in chronic low back pain and avoid the morbidity and mortality that is often associated with prolonged low back pain. Previous research has shown that early intervention and treatment of injuries by athletic trainers embedded in various clinical sites has reduced the likelihood of injury-associated disability. Our research did not explore patient outcomes when related to the management of low back pain by athletic trainers. Future research should investigate whether care provided by athletic trainers for low back pain leads to favorable patient outcomes. Athletic trainers provided 3,817 services to patients with low back pain, with the most common individual services being hot or cold packs, manual therapy, and therapeutic exercise. Since previous research cannot support a single form of exercise or manual therapy as the most beneficial when treating low back pain, and multiple CPT codes can be categorized as either therapeutic activities, hot or cold therapies, or manual therapy, these CPT codes were grouped together. When combining all services that can be categorized as therapeutic activities, therapeutic interventions were the most common service provided with 1,152 units of service. Hot or cold therapies were the second most commonly provided category, and all services that can be categorized as manual therapy were the third most common provided service. Previous research has supported the use of therapeutic activities and manual therapies for treatment of low back pain in acute, subacute, and chronic phases, and have moderately supported the use of heat therapy in treating acute low back pain. Clinical practice guidelines have been developed to provide clinicians with the best medical evidence available to aid in providing quality, patient-centered clinical management when combined with clinical expertise. Multiple clinical practice guidelines exist. However, there are not specific clinical practice guidelines for every patient setting in which an athletic trainer may provide care. It is recommended that using clinical practice guidelines for the general population would be beneficial when treating low back pain for patients that participate in strenuous activity. Adherence to clinical practice guidelines has been shown to reduce pain and disability. Furthermore, patients perceive more improvement in pain and disability when receiving care from clinicians that adhere to clinical practice guidelines. While there are multiple clinical practice guidelines for low back pain, major themes exist among the available guidelines to guide practitioners in treating patients. Major themes include focusing on pain education, psychological support, and therapeutic interventions that involve active therapeutic treatment and rehabilitation that progress the patient to a full return to function. Based on our results, it appears that athletic trainers involved in our study may be following some recommendations of clinical practice guidelines, but our study did not specifically address this. We also did not study interventions related to psychological support or pain education. Future research should explore athletic trainers' use of clinical practice guidelines when treating patients with low back pain, as well as patient outcomes when athletic trainers manage low back pain based on clinical practice guidelines. Our study was not without its limitations. The sample size for this study was small. However, the percentage of patient cases included was higher than similar studies conducted through the AT-PBRN. We were able to include 61.17% of cases related to low back pain in our study. Given the percentage of cases that met inclusion criteria, we feel our results are a good representation of care provided by athletic trainers for patients with low back pain. Considering previous studies citing barriers athletic trainers perceive to patient care documentation, the total percentage of cases included in this study may reveal that athletic trainers are improving patient care documentation. While we have begun to address gaps in literature by describing patient, injury, and treatment characteristics of low back pain managed by athletic trainers, there is more to be explored. Future research should assess patient outcomes related to athletic trainers' management of low back pain, as well as explore the direct cost of care associated with these services. Researchers should continue to aim to provide a comprehensive image of care provided by athletic trainers and demonstrate the value of having direct access to athletic trainers in various patient settings. Before concluding, I want to take a moment to thank Dr. Kenny Lamb for his invaluable help and guidance during this process, as well as thank the members of the Athletic Training Practice-Based Research Network for their continued commitment to providing patient care and advancing the profession of athletic training through data collection and research.